Hi, Becca.
Hi. How do you prefer to be addressed?
You can call me Dr. Kudzai. I don't, whichever is easier for you. Some people find it easier to say Dr. Dombo, and then some people have a little bit of a difficulty wrapping their heads around Kudzai.
Kudzai?
Yes.
Okay. Well, thank you for taking the time
Yeah,
to chat.
absolutely.
I
Absolutely.
put a little question. I mean, I will start by saying I am so new to all of this. I literally found out about the existence of perimenopause from Alloy
Oh,
reaching
wow.
out to me, being like, "Hey, so you're of age," and I was like, "Delete. What do you? I don't even know what you're talking about." Um, and then started looking into it. I was like, "Oh, I guess this is a thing that I need to think about," and it was just something
Wow.
I'd never really talked about before.
Right.
And so I've just been really diving into it over the last year, and I uh, sent a little question box out to my community on Instagram yesterday and got so many questions from people. Some more general about symptoms and about treatments, and then some that are like a little bit more specific to
Yeah.
people. So I think it'll just depend on what you're comfortable
Yeah. Yeah.
answering.
Well, Becca, can you tell me maybe just even to start out, can you just tell me a little bit about yourself, your community, just so that I can also get to know you? I mean, I kind of know you a little bit on paper, but I would love to be able to hear
Yeah.
a bit more about you as well.
So I'm 43. I live in Los Angeles. I'm body neutral is like the way that I talk
Yeah.
about it.
Yeah.
So I attract a lot of people. I sort of started my online platform with ED recovery
Yeah.
and body positivity, which sort of like transformed into body neutrality. So I have attracted a lot of people trying to push back against societal norms and the things that they've always been
Yeah.
fed about the way they're supposed to show up
Yeah.
in the
Yeah.
world.
Yeah.
Yeah.
Thank you. It's always nice to hear it from you.
Hmm.
And it just helps me really bring context to everything. So yeah, thank you for, what you've committed to do for, a community, because I think it's always important, even when it comes to perimenopause, community is such a huge piece. Like when I share with like, especially like, Black women or, brown women, just the space of community is what tends to make the landing a little bit like easier.
Yeah.
Why don't we dive in? Are there specific questions that you have for me? Anything that you would like me to, just share with you in regards to, perimenopause, menopause, and what your community, what would be beneficial or helpful for your community?
Yeah, I think that a lot of people are questioning basically like what the signs are, what the signs and symptoms are, what to be looking out for. And then there's a lot of people who are being, a lot of folks are asking in their mid 30s up into their mid 40s, and then even being told by their doctor at 43, 44, 45 that it's too early for them to be thinking
Mm,
about any of this. And
yeah.
so, what are the things that people should be looking out for
Yeah.
and can bring to a medical professional?
Yeah. So I think, that's such a loaded question.
Yeah.
And I usually like to, this is what I just share with patients just to really try to simplify it, right? So we know what menopause is, right? Menopause is 12 months with no period. And we know the average age is 51 plus or minus 5 years. Perimenopause can be anywhere from like 4 to 10 years before that. So your late 30s, your early 40s, you can start to experience what we call perimenopause. Peri means perimeter, around, the time around. And so when I think about, what defines perimenopause, I think of, okay, there are two things that as a physician, since there's no diagnostic test, that I can actually say, okay, I did this test and it tells me that you're in perimenopause. There are two things that I really look for when I talk to a patient. One is like menstrual irregularities. Have you noticed that there's been any kind of pattern of change in your periods? So has the time between the first day that you bleed each month shortened? Has it lengthened? Have your periods, gotten longer? So let's say you were bleeding every 5 to 7 days. Are you now bleeding 8, 9, 10 days? Or are you having these episodes of prolonged bleeding where you're just bleeding, for 20 days and it's
Yeah.
just no end in place? Or are your periods significantly heavier? So that's one component, right? So you may or may not have that. But then the other component are symptoms, right? of menopause. And we know that now they're about 100 symptoms associated with it. So, you can have one or the other or both. And so that's kind of where it's like it's really important that you track, your cycles and you kind of have an idea of what's normal and then what may be outside of normal for you. And then the other thing is like looking at some of the most common symptoms and the not so common symptoms. And if you see that you're having like a cluster or a collection, because it's like, okay, if you're just having one symptom, maybe not be perimenopause. But if you're like looking at a collection of symptoms that you're noticing, and obviously, the symptoms that I always tell patients, it may not be the hot flashes and night sweats, right? But it may start with like mood symptoms. You may start to notice that you're having depression, anxiety, irritability, inability to tolerate stress. You're having disturbances with your sleep. You're not able to sleep very well at night. You're noticing that this is becoming a pattern, right? It's not just oh, it's associated with this stressful event, but it's becoming a pattern. So that's why it's always so important. I tell patients, please track your cycles and track symptoms that you're having because sometimes those symptoms may start to show up in the luteal phase, which is the phase right before your period, because that's when your estrogen naturally drops.
Mm.
But then you may start to notice that, wait a minute, these symptoms are happening, consistently for me. And I just can't understand rhyme or reason as to, this conglomerate of symptoms and what's causing them. So
I
again,
think, yeah, that's also really good, I think, to note for people. We're sort of the first generation who have been on birth control our whole lives. Like, I was put on the pill when I was 17 years old and have
yeah,
been on the pill or had an IUD for basically my entire life.
yeah.
So I think there are a lot of people who don't really know how to track their cycle in that way because their cycle has always been managed for them.
Right. But here's the key thing, because I also see this in women who end up, and I don't know if, the later age demographic of your community, but I also see this on women who are on the birth control pill, who they say, I've been on the pill for years, and now all of a sudden I'm having hot flashes. And
Interesting.
despite being on the pill, they'll start to notice a change in their symptoms. So they're having these symptoms despite being on the pill. So that's where I think, you know, that's another key indicator. Wait, you're on the pill and you're still having those symptoms?
Yeah.
That's like, wait a minute, we need to kind of investigate further.
Okay. Cool.
But
That's
again,
really great to
if
know.
you want me to go into a lot more of the symptoms, you can let me know because I can list painful sex, body odor change, dry eyes, dry mouth, itchy ears, ringing in your ears.
Dude, the number of people who wrote in being like, my ears are so fucking itchy.
Mm-hmm.
Like the itchy ears thing seems to be, I was like, I had no idea. There is no
Right.
world in which I would have connected itchy ears to hormonal changes. But yeah, the number of people who were writing in about that was,
Right. Right. So that's why I'm like, what I'm saying is that there are tons and tons and tons of symptoms. And I think it's like, it's really important that, you know, you're aware that, hey, it's a collection, right? It's a collection of different, maybe body parts
yeah.
experiencing that.
Do you have that? I know it's like 100 things, so I don't want to make you rattle them off, but is there a list that I
Yeah.
could
I
see, just
could,
have bullet points? That would be
yeah,
amazing.
I could do that.
Yeah,
Sure.
I would love that. A lot of people are also asking about PCOS
Hmm.
and the like, how can you tell if it's PCOS or if it's perimenopause, and when do you know that it's
Yeah.
sort of like switching what the changes
Yeah,
are there?
yeah. So I think it's really important to note that with PCOS, the diagnosis comes way sooner than perimenopause. So a lot of times women will start to notice in their 20s, right? Like PCOS is typically you're not diagnosing PCOS for the first time at 45.
Hmm.
So you're really looking at in your 20s, your early 30s, like that's kind of when we start to kind of notice a pattern of, wait, your periods or you're skipping like 3 months at a time. So 20s and 30s is really like the age at which we're not looking at perimenopause. So I think it's really important to distinguish that, yeah, having PCOS, yes, you can transition into perimenopause, but it's my alert goes off when I see a 27-year-old coming in telling me that her periods are abnormal. The first thing that I'm going to think of is doing a workup for PCOS and
Hmm.
where your testosterone levels are, your androgen levels, and is that what's interfering with your ability to have regular periods? So
And so then when it comes to those, yeah,
yeah, because
sorry.
you're going to have weight gain with that, acne, maybe what we call like hirsutism, where there's like excess facial hair or hair in
Hmm.
certain parts of your body. So yeah, the excess facial hair, weight gain, acne, acanthosis nigricans, which is a dark, line at the back of your neck can be associated with that. And then also, just the menstrual irregularities. And some women may have menstrual irregularities with none of the other symptoms. Some women may have all the other symptoms, but their periods are normal in PCOS. So that's why, again, it's more of a diagnosis, 20s and early 30s.
Yeah. And then when people get to that point where they are in their, say, in their 40s or, and heading in towards menopause, then like, will there be different changes in someone with PCOS
Yeah, yeah,
than
yeah.
without to look
Absolutely.
for?
Because your body is going to change, right? So a lot of times I have, a few patients actually who they have PCOS. They've been on the birth control pill, right, to regulate their cycles, right? So they're on the pill, but then as I mentioned, that you may start to have other symptoms. One, she actually ended up being on the progesterone only pill because with PCOS, being overweight, having metabolic syndrome, she ended up with high blood pressure, so she didn't want to be on a estrogen birth control pill. So she was on the progesterone only birth control. But again, she's 46, started developing hot flashes, all the symptoms of perimenopause. And that's where we were able to add a transdermal estradiol, to help her a little bit. So it sounds difficult, but I think for us who've been trained, it's not so difficult in helping women through that transition.
Hmm.
You go from PCOS into perimenopause because as a woman, you're just in tune with the X chromosome. You're in tune with what is going on in your body and the changes that are occurring.
Yeah.
So it's not difficult to miss.
Yeah. So as far as like doing labs or hormone tests or any of that, so you're saying that there isn't really a test that you can do for perimenopause.
No, not to
Yeah.
diagnose you for perimenopause, because that's why I think a lot of women feel like they've been dismissed because they'll go to their doctors, they'll get their blood drawn for their hormone levels, and they're told their hormone levels are normal, right? Because a lot of times when we talk about hormone levels, we're talking about estrogen, progesterone, maybe LH and FSH, which are the brain's signals to the ovaries to produce estrogen and progesterone. You can get it's important to get your thyroid checked. It's important to get all the other hormones, checked as well. But when I'm talking specifically about estrogen and progesterone, during perimenopause, you have these wild fluctuations. So in the morning, you could be low, in the evening, you could be high with your estradiol because of the fluctuation. So there's no real way to measure, oh, is this it's very individualized
Yeah.
because everybody is different. Number one, in their medical history, right? In their, like so in their family history. And it really is like when your symptoms are bothersome enough to you that it's interfering or impacting with your quality of life, that's when it's worth having the conversation, right? I mean, it's worth having the conversation even before you get to that point, so that when you get to that point, okay, boom, this is where I am, and I'm really ready to start. So I think we really look at because it's really symptomatic relief that we're aiming for when we
Hmm.
start you on something. So again, only you can say. But we really assess a lot of different factors when you get evaluated. It's really a very personal decision.
Got it. Are there any like before if people are before the point where they're comfortable doing like hormonal interventions, are there any sort of like lifestyle or like natural or supplement sort of changes that you
A
recommend
hundred,
for
a
people to
hundred
start
percent,
introducing?
100%. I tell like hormones are just one piece of the puzzle. They're just one piece of the puzzle. It's really important when it comes to lifestyle because like you think about the cognitive changes that can occur, right? With perimenopause, when you start noticing that your memory goes, or you find that, oh my gosh, I feel like I'm just in a fog, like I'm just experiencing,
Hmm.
right? Like exercise is so important to because it increases blood flow to the brain. Okay. And it also improves the elasticity. Okay. Because the brain is not this organ that, oh, once, but it's malleable. So more brain flow will improve elasticity. Doing like I tell patients, find a new habit, or find a new skill to learn. Because if you're having cognitive changes, your brain needs its own level of doing something that it's never done before. So there's that neuroplasticity. So it's really important. Like when I say exercise, exercise is important for brain. Okay.
Hmm.
It's important for your muscles because you start to lose muscle mass, right? When you enter, um, you know, uh, perimenopause and menopause specifically, you lose muscle mass. So the more you have built, your muscle going
Hmm.
into the transition, you are way better off. And then also your bone density. So when the estrogen levels drop, you're not like, oh, at the mercy of just your bones, like getting impacted.
Yeah.
But if the more you're, moving your body, the more you're exercising, doing resistance exercise, you are working on a long-term, a longevity plan. Okay. It's really your longevity. And then the other thing that you asked, okay, nutrition. Let's look at, when you enter perimenopause and menopause, because it's really harder once a lot of the metabolic changes have occurred within your body. You want to go in with all the nutritional support, increasing the amount of protein in your diet, increasing the amount of fiber in your diet. You want to make sure that you're accustomed to, like I never liked rolled oats, in almond milk in the morning. But that's now my new go-to because I feel the immediate effects in my, mentally in the gut. It's just that gut-brain barrier. But it's knowing that going in so that you're not trying to make all these changes all at once.
All at once. Yeah.
Yeah, after, you know,
Yeah,
the,
that was one of the questions that I got was, do I really have to eat a bazillion grams of protein every day?
here's the thing. If you're in like I would say once you get to menopause, okay, that would be something important. But in perimenopause, that's when you should start training yourself.
Start
Okay.
ramping up. Yeah.
Yeah, to start ramping up. I tell patients it's not this overnight, like everything has to change because you're setting yourself up for failure if you do that. It's really like, okay, I'm gonna just maybe do one thing different in my diet. And it's gonna be like, if I just start paying attention to the amount of protein that I have. I mean, Dr. Vonda Wright, it's so funny. What she does to increase her protein, she's like, and Vonda Wright, she's just known, she's an orthopedic surgeon and she does a lot of longevity and menopause work for women, and she
Hmm.
basically says, I eat a chicken breast like a lollipop. So in between patients, she will take a fork, a chicken breast, and she eats that in between patients because she's just like, I'm doing it for my protein, and then she puts protein in her shake in the morning and then she eats, an amount of protein at night. But she's at a place right now, she's 57. So she's like, I'm postmenopausal and I need to make sure, right? I'm not telling a patient who's, you know, early perimenopause that, oh, that's exactly what you need to do, but you should start just thinking about certain things.
Yeah. Yeah, no, that's great information. I also, as somebody who's like, you know, had an ED for a long time, I like to think of things in terms of additive things, especially diet wise, rather than restrictive. And so, like adding protein
Yes.
in, adding fiber in, that's like a
Yeah.
great way to sort of wrap a brain around it. I think, especially in my community, that's a thing that a
Yeah.
lot of people
Yeah.
deal with. There's been a
Yeah.
lot of like, you have to cut this out, you have to cut this out. So it's nice to
Yeah. Yeah.
hear
It's
it the
just
other way around.
it's just really like just again, it's just small shifts.
Yeah.
Adding beans, for example. I never liked black beans as a side, but I almost eat that with almost every other day. I have that on my plate.
So a lot of people obviously are asking questions too about when it comes to hormonal treatments and cancer risk. And
Mhm.
then also for people who are like more prone to estrogen related cancers, if they have like, whether it's family issues or or anything like that.
So I'm wondering if they are concerned about the risk of breast cancer. Is that, or is it just just in general?
Let's see. A couple of questions I had. Estrogen patch, asking about estrogen patches with an increased risk of breast cancer, if there's any support for that. Is there any treatment option for those of us at risk of estrogen related cancers? Yeah, when is it appropriate to start HRT? Is it okay if there's a history of cancer in extended family? I think it's a lot of
Yeah,
those types of
yeah, yeah.
questions.
So I'll address the very last question first because that's the easiest.
Yeah.
If you have a family history of breast cancer, that does not mean that you cannot take hormone therapy. And here's the thing, I think it's so important because, this is just such a basic concept. The birth control pill. Everybody seems, even if they have a family history of breast cancer, it just doesn't seem like that's something that they would have any hesitation taking. Hormone therapy is a fraction of the amount of hormone in compared to the birth control pill. A fraction. So it's really interesting because I know the mental gymnastics we have to take to really keep things in perspectives because of the damage that was done by the Women's Health Initiative in 2002. But hormone therapy, all we're doing is just replacing what your body would naturally produce. It's a very small amount to help with symptoms. It doesn't even shut down your ovaries like the birth control pill does. So you've had a family history of ovarian cancer. That is not a contraindication to taking hormone therapy. Okay. So I tell that to all my patients. It's not a contraindication. Let's say you've had a very strong family history and you are a BRCA gene carrier. That is not a contraindication. So I think it's just really important to put it in perspective because a lot of times
Yeah.
BRCA gene, like let's say you have the gene, a lot of those women have already had a what we call a mastectomy. They've already had their ovaries taken out, and basically they are in a space of estrogen deprivation, which can impact their entire bodies. And so what we do recommend is actually putting them on hormones, bioidentical hormones. And so that's where, again, when you look at your risk for breast cancer, you want to make sure you're looking at very specific types of hormone therapy. And that would be like a bioidentical hormone therapy, which even reduces the risk even more. So that would be what I would say to the family history. If you have a personal history, again, if you're a BRCA gene carrier, again, it's not a contraindication. It's just that it's really important that we talk about, hey, have you had a mastectomy? Have you had an oophorectomy? What is it that's safest for you? Because again, it's not a contraindication. And then hormone therapy has been found protective in colon cancer, for example. That is found to be more protective, like it reduces your risk, for colon cancer. So it's important to kind of know that side too.
If you stop taking um, HRT, did the symptoms come back?
It depends. I mean, if you stop taking it at age 49, if you stop taking it at age 59, if you stop taking it at 69, it really is very individual. And so here's the thing. If you stop taking it, let's say you decide to stop after 5 years, because some people are like, oh, I don't want to be on it longer than I need to. I just kind of want to do it for the time that it would be beneficial. So some people have this arbitrary 5 year time frame. You know, you can stop it, see if you do have hot flashes and night sweats. And if you do, then you can go ahead and restart it again. And we assess you, we look at any changes in your medical history over time, right? Let's say you decide that you want to be on it for 10 years. I always tell patients it's important that you keep me updated to know if there are any changes in your medical history, because if there are, we may need to make adjustments.
Hmm.
So there's not a hard and fast rule. So again, the answer to that could be for some women, they may stop and they don't have symptoms. They've gone through the transition and they have absolutely no symptoms. Boom, and they just stop it and they're good. Others, they may try to stop it, but they're still kind of in the transition. They may want to restart it for a couple of years and then again, every year you can decide to taper and see how you do. But it's very much not a one size fits all answer to that question because it's
Yeah.
dependent on your body.
Yeah. And so there a point, I guess this is just the things that our moms don't talk to us about. Like, is there a point where the symptoms taper off? So like obviously like
Ah,
you're in perimenopause and then you're in menopause and then you're
yeah.
postmenopausal. And so then in the postmenopausal phase, the
Again,
symptoms sort of taper. Is
yeah.
that just, I mean, obviously individual to
For
everyone, but
some, it's very individual, but for some women, I get some women who feel like, yeah, their symptoms just they just are not in a space where they're experiencing symptoms, that were as bothersome as they did before. I have some women are like, you know what? No, I tried to stop and my symptoms are still there and I want to be able to continue. I have a 72-year-old patient who's still on her estradiol patch that she's been on for, I think, 30 years, so it's very, unique and just because some people feel good on it, they may just want to continue.
Somebody says, do we actually need new skin and hair care for Perry, or is this more patriarchal marketing?
I think it's just important to know that when your hormone levels start to shift and adjust, it may have an impact on your hair and your skin. And
Yeah.
for each person, it's going to show up differently, right? So the decrease for me, my friend is the one who was like, Kudzai, I'm seeing Meniere's lines here. Okay. She said,
Hmm.
use those words. And that, I kind of knew that my skin was changing, but not to the point where it was noticeable to somebody who I've known for 20 years. Okay. And at that point, I was just like, oh snap, I need to improve the collagen, in my skin. I want to do that. But I would have wanted to do that before those changes, had happened because I know how much harder it is for the body to reverse something.
Hmm.
So I'm not giving an answer that's, oh, this is what you have to do.
For
I can
sure.
only share with you that knowing how the human body works, it's always harder to reverse changes that have occurred. And for myself, I'm very grateful. I'm 51. So I was able to look at what I could use to help my skin feel vibrant again.
Hmm.
So, and I, you know, caught it at a time where I thought, okay, I think I was 49 when, she started noticing those changes. And but that's my personal story. But I do
Yeah.
think that it is inevitable that our skin is going to change as the estrogen in our system declines.
Yeah.
So,
And it's just about what you decide that you want to do about it,
yeah,
which is the whole
exactly.
part. Yeah. I think it's funny because I get caught up in that question with people because I'm like, patriarchy part of it actually feels to me like the lack of research around, and like available information around
Yes.
all of this, because if this
And
happened
I'll tell
to,
you, I did the M4 before I even worked with Alloy. So I went to the Menopause Society in 2023. I went to their in-person conference. This was the first time I did it in person because of COVID. And that's where I heard a doctor do a whole lecture on the skin change. She was a dermatologist, the skin changes.
mhm.
And so then that's when I was like, oh, and this is before I worked with Alloy. And I was like, oh, I'm gonna get myself M4. And so I did that and I did it, I think, for 3 months. But for me, what worked was the combination of a retinol with the M4 to make changes for me. Because that's when my Meniere's lines were already there. So, for me, I noticed, oh, this combination actually works better than just using M4 by itself, where I'm
Yeah.
at. And so that's what I'm
Well,
saying.
yeah, and I was already using tretinoin, and then I started using M4, and I was like, oh, why does my skin feel like a baby's butt? I was like, but it just felt so soft and plump again in a way that I couldn't
Yeah.
really like describe to someone through a
Yeah.
phone
So I'm
screen,
not
you
giving
know?
you statistics or any numbers, but I'm just kind of answering this. I mean, if you want statistics, I can definitely provide that information for you based on, the information that we have.
A lot of people's questions did have to do with their symptoms, right? So the itchy ears, like I mentioned, night sweats, and um, having trouble sleeping, hair loss. Some people were talking about your body reabsorbing your labia, how to avoid repetitive UTIs,
Yeah. Vaginal estrogen.
joint pain.
You know what's so funny? As an OBGYN who's been doing this for 20 years, um, it's something that we just see and it's like, oh, that's just part of how the body changes, right? And so now that it's a hot topic, it's just hilarious because for us it's so basically here's what happens. And this is more specific for when you're postmenopausal, right? And your estrogen levels really tank. So estradiol is responsible for again, producing secretions within the vaginal tissue, within the bladder, maintaining again the strength of the tissue, the elasticity of the tissue. So when you don't have that elasticity and that collagen, you know, in your labial areas, they just gradually get smaller and smaller and smaller. And so again, when we see women who are much older, it's just a fact that we see. But it's true because think about it, like your estrogen levels are what are responsible for collagen, for, the matrix, the matrix that supports the cells and makes them plump and, produce, just whatever secretions. When all of that is stripped away, like there's just dryness, and no elasticity. And so things just gradually, what we call, they atrophy. And so that is the kind of word that had been used. We
Yay.
don't use we don't
Yeah.
use vaginal atrophy anymore. It's really the genitourinary syndrome of menopause. And that's what so vaginal estrogen is one of the, very low dose estrogen creams, applied not only internally to help reduce painful sex, but also externally to make sure that, again, the clitoris, the vulva, all of those tissues maintain their health and elasticity and their
Got
ability
it.
to just be plump. So
Got it.
that,
So like that's where so just like you're using a face cream and you're using
yes,
vaginal cream and then you're taking hormones for like the more internal symptoms.
right. So like your hot flashes, your night sweats, your
Yeah.
night symptoms, like your systemic, we call them systemic symptoms,
Systemic.
meaning
Okay.
like your
Yeah.
your whole body symptoms. That, yeah, but the topical estrogen that's used for recurrent UTIs, because again, it really makes sure that the bladder tissue is again, it's got that matrix. It is because once it loses that matrix, it becomes very much more prone to bacterial infections. So when we apply it topically, it's not absorbed into the bloodstream. Like it hasn't been shown to have significant amounts that are absorbed into the bloodstream. And so that's why we say you can use it in addition to your systemic hormone therapy.
Great. Thank you. I'm trying to see what other questions are here. I know we're sort of on the end of this. Do you have any book recommendations or like things that people can like read up on if they're, feeling a little bit lost at sea?
Yeah. I mean, I don't, the book Estrogen Matters is what I would say is key for, it's by Avon Blooming. It's key for, the concern around breast cancer because he's a breast oncologist and both of his wife and his daughter had breast cancer and they used hormone therapy. So it just kind of puts things in perspective for those who are concerned about a family history and those who are concerned about, that kind of thing. I think there's also the new menopause, which also kind of puts, Mary Claire Haver's book, it kind of gives real life examples,
Yeah.
of what women have gone through. And then I think, Sharon Malone has a great book in terms of how to navigate the health system, when you're looking at, okay, I'm dealing with my insurance. I want to stay in network. How do I navigate the health system? And what are some things that I need to think about that I can do before I encounter the health system, and what, that side may bring to me. So she has very practical, very, very practical, ways to
Okay.
address those things. So I like,
Awesome. And then what would you say to people who are, because I think this is sort of like, it's just such a big part of it, like trying to navigate all of the information and say, like, what is fear mongering versus what is marketing versus what is
yeah,
truth versus what is me just listening to my body.
yeah,
Um, especially in a system where a lot of people's doctors aren't necessarily giving them the resources that
yeah.
they need yet.
This is what I say all the time. I say number two things. I say find a trusted resource, okay, for where you get your information. And then the second thing is the community. It's huge because you need a safe space, right? Other people dealing with the same thing, and other people can call out when there is fear mongering, but I think it's important that you have like this community of um others who may be in the same place, but then that community doesn't necessarily only include people who are the same age as you, because I think what I've seen in some of the rooms that I've been in, sometimes the older generation can be such a great connector because sometimes it can be intimidating, right? To be like, oh my gosh, like this is just depressing. Meanwhile, going through the process, there are so many women who, on the other side, have been able to like hold on to what is absolutely amazing about going through the transition and the liberation, right? The reframe, the respin, the however you want to, whatever you want to call it. But it doesn't like your story is not ended with what you're dealing with. There's a side that comes with all of this that can be really beautiful. So,
Yeah.
but it has to, trusted source. I don't, find a trusted source of information, people who you can really trust.
Yeah. Yeah, and I think that yeah, opening up those conversations is part of what I'm really trying to do here too, and make sure that we have a space to talk about this because it's scary out there just in the world right now, and I feel like with there's a lot of misinformation and disinformation,
Yes.
especially around health, that is going around, and so I think people just trying to parse all of that out. It feels really complicated, and it's scary to be going into this phase. And I feel like we are the first sort of like internet native generation that is going through this. I've said that out loud, and then Gen X gets, sorry, I know you're Gen X, but like Gen X folks get mad at me for saying millennials are the first ones like doing this out loud. They're like, we have too. And I'm
No,
like, but on the
it's
internet, y'all,
true.
in this space, on TikTok, on Instagram, it's just gonna like open up a whole new world of people being able to find their people and find that information
Yes.
and being able to share in it
Yes.
and feel less alone and a little
Yeah.
bit less scared. Thank you so much. It was really lovely
It
chatting
was
with you. I really
lovely to meet
appreciate it.
you.
Yeah.
Absolutely.
Thank you
Bye-bye.
both.
Okay.